So good morning. We are about to start this meeting. The meeting will be held in English, as we are pleased to have among our guests Professor Joseph Doyle. Welcome. Who is Professor of Management, MIT Sloan School of Management, United States. And so the meeting will be in English with simultaneous translation for those of you who wish to follow the lessons, the talks in Italian. Today we are talking about measuring performance in healthcare. And as the director of a school and as physician myself, and as director of a medical department in my previous career, career until 2 years ago, I'm particularly pleased to give you a welcome to this meeting. Measuring performance in healthcare is a quite important issue because people tend to think that healthcare is something that doesn't need to be measured. This was in the old days. Healthcare is, especially in Italy, we have this concept. For a long time we have had this concept that healthcare is a right. Is something that does not depend on, should not depend on any other issue, that not the only one, which is to take care of a patient. To take care of a patient doesn't matter how much this may cost or these things. But healthcare is a business, basically. Healthcare is a cost. Healthcare is the greatest cost for any region. I believe, I think Professor Nuti can confirm this, that for Tuscany region, where healthcare is pretty good, the budget for healthcare is about 85% of the whole budget of regional budget. So this little information itself gives you an idea that healthcare really impinges upon the everyday's life and monetary budget for the Italian state and for regions a lot. In Italy, we are lucky enough to have free healthcare, essentially free. Every citizen is entitled to have healthcare and medical assistance, actually even before he or she is born, right? So is during maternal gestation. It's not the same in other countries. In the United States, it's quite different. And I learned this the hard way, so to speak, in 1989, when I moved to the United States, when I lived for 10 years, and I lived there as an American almost citizen because I had the green card, and I had my medical degree. I took the validation of my American degree in the United States. So after a while, I was almost a citizen. In the United States, at least at those times, you had healthcare only if you had a job, and the healthcare, I don't know if now it's changed a little bit, healthcare was not a right. It was something that you had a right to have only if you had a position, a job, or you paid by yourself, essentially. And depending on which kind of job you had, you could have a better healthcare or healthcare with a lot of limitations. Especially for mental health, I remember. And being myself a psychiatrist, I noticed that for some pathology, some disorders, the limitations that were inside the healthcare system were really a problem for families. So, healthcare is a right, but it's also something that has a lot of cost, and measuring performance means to optimize the service that the state and the region give to the citizens, containing the cost or making the single dollar or euro in our country pay the better, so do the better job possible. And this is not always the case, even not so far away from here, I mean, not in some unknown land in Italy. There are a lot of things that have been and still can be ameliorated in terms of improving the cost effectiveness of a service. Today, we have probably the major experts in this part of the world, because Joseph Doyle who I already introduced, is professor of management, MIT Sloan School of Management. He's one of the greatest experts on the team. And in Italy, Sabina Nuti, who is professor of economics and process management at the Scuola Superiore Sant'Anna in Pisa, has a long story and is well known for her studies and measuring performance in healthcare. And she does this for the Italian state, basically, for the Tuscany region and other regions as well. And Massimo Riccaboni, who is professor of economics here at the IMT school with us, is a professor of economics with a long experience in the healthcare systems. Actually, Massimo Riccaboni sits in the AIFA, who is the Italian Association for Pharmacological Regulation. So it's the most important regulatory agency in Italy for pharmacological, for drugs, basically for releasing new drugs and monitoring drugs and establishing also, Massimo, I guess, the prices of drugs. So, which is a quite important issue. If you think, for example, of a recently admitted treatment for hepatitis C, right, which is very expensive, but is very expensive for a single patient, but then the real costs and benefits should be calculated in terms of what it means to eradicate hepatitis C among the population. As you may know, hepatitis C is the major risk factor for liver cancer, and this means that you may eliminate a source of pathology really relevant for citizens. So I'm not going to put more words and to make time go by with my introductions. I am very pleased, and I thank all the speakers for being here today. Very pleased that we are here today at the school to discuss this. Last but not least, as we used to say, I like to say that I'm particularly happy because this is a conjoint activity between ourselves and the Scuola Superiore Sant'Anna. Scuola Superiore Sant'Anna is one of the other 6, actually other 5, including us, schools with special status that are in our country, and we are more and more collaborating and actually coordinating activities, and we're trying to do as many things as possible conjointly and together. So this event of today, which is held here at the IMT school, which I have the honor to direct since November 2015, is one of these events, and so therefore particularly pleased that this is another of the conjoint activities. So thank you for being here, and please, the first speaker, so I should call the first speaker if anybody else is here, I think is, the first is Professor Joseph Doyle, who is Professor of Management, MIT Sloan School of Management, and we'll talk about measuring returns to healthcare. Thank you.
Okay, good morning. Thanks for everyone for coming. Thanks Massimo for inviting me, and for Alice and Chiara for helping me organize my trip. It's been a beautiful time for me to visit Lucca for the first time. It's a beautiful city, and it's my pleasure to be here. I think I'll talk for 25 minutes, and then we have some questions, and then we'll have the other speakers come up and have questions then and also at the end. So I think that's the plan for today. What I'd like to talk about are measuring returns to healthcare. And I think of that in terms of a broad set of categories. If we basically pay for more of the newest technologies, the newest pharmaceutical drugs, the best physicians, do you get better outcomes? Is it worth it to spend more in order to get better health outcomes? So I'll talk a bit about healthcare costs, and then potential value, and then credibly measuring the value. So here's a graph of the OECD countries, or a subset of them, of their healthcare spending as a percent of GDP from 1970 to 2016. So what you see in red there, the dark red, is Italy, and it's sort of in the middle of the pack of OECD countries, looking at 7 to 8% of GDP. There's a line at the top there that's a little different than the rest. That's the United States. So we are number one in terms of spending a lot of money on healthcare, which makes it particularly interesting from a fiscal standpoint in the US, but also in most countries. You see all the countries are going up over time, just the US is going up a bit faster. And so this is the type of thing that we talk about in the US, but it's also in many European countries, that's what's called the cost curve. And this is the fraction of GDP that would be spent on healthcare if we continued at that increasing rate of expenditure, the inflation from medical spending. And so you'll see by 2080, we'd be spending our entire budget on healthcare. That's obviously unsustainable. So we want to know what would happen if we slowed the growth of the healthcare. Well, if there are returns to healthcare, if we spend more money, we actually save lives, there would be a cost to slowing that growth. If most of it is waste, where the increase in spending is not helping people, then it will be wise and efficient to reduce our spending on healthcare. So that brings us to the question of how do we measure returns to healthcare, or is higher spending worth it? So one way you could look at that is life expectancy. It's albeit a crude measure of whether healthcare systems are doing well, but here's a scatter plot of total expenditure of healthcare per capita on the x-axis and life expectancy on the y-axis. And you can see it's generally an upward sloping relationship. Mexico at the bottom left there, with average life expectancy of 75. And as they spend more, the UK, for example, you get up to close to 80. You do see a leveling off, however. There are many countries there clustered around 80 years old, despite very different spending levels. And then, of course, there's one that's particularly different, which, again, USA, number one in terms of potentially wasteful healthcare. So we're sort of off the map of how much we spend in the US, and then we're not doing better in terms of life expectancy. Of course, there could be many reasons for that. I would think the Mediterranean diet is always raised as a potential explanation for why people in France and Italy live so much longer than the hamburger eating people of the United States. So another way you could look at returns to healthcare in a sort of broad, crude way is life expectancy over time. So before I was showing you life expectancy across countries. This is life expectancy across time. I picked this one because it's the US, it's something I'm more familiar with, but back in the mid-1800s, people were living average life expectancy about 40. A lot of infant mortality would be a reason for that. But you can see this sharply increasing gain in life expectancy over the 1900s. And economists, we like to put dollar value on things. So what we've done is we've come up with ways of valuing increasing the chance that you'll survive a year. So what's the value of life? We'd have to talk to philosophers, and maybe it's infinite, the value of life. But what's the value of changing the likelihood that you'll die over the next year by 10%? The way we do that is we look at markets in which people pay to reduce their risk of death. So there are markets in terms of safety equipment on vehicles. You have to pay more to get a safer car. There's wages, so you get paid more if you're in a more dangerous job. And so we use those market prices to try to back out what people are willing to pay to be a little safer. And if you use those estimates and you look at this change in life expectancy from 1970 to about 2000, economists estimate that in the US alone, the value of that would be about $70 trillion. So whether you would think it's 60 trillion or 80 trillion, there are assumptions that go into that number. The point is that it's extremely valuable. We are willing to pay a lot of money in order to become a little bit safer. And so is it worth it or not? Well, it's sort of how much do you want to pay for it? We were saying we spend about 18% of GDP on healthcare. Is that too much? It's a lot more than other countries. But if I think about your budget, how much do you want to spend on being healthy? increasing your chances of surviving if you get cancer, maybe you would be willing to pay a lot for that. So I wanted to caution you, though, that that was a graph up until 2000, and right around 2000, the U.S. had a stagnation in terms of improvements in life expectancy, especially for middle-aged whites in the U.S. So these are middle-aged whites from 45 to 54. You can see that the mortality rate, 400 per 100,000, sort of got its low around the end of that previous sample period, and it's been going up over time. It hasn't been doing that in other countries, though. You can see France, Germany, UK have continued to see declines in their all-cause mortality rates. So there's, for this age group. So there's something particularly going wrong in the US. We attribute it to drug, alcohol, and suicide mortality, something about, I think it's tied to mental health, but also the availability of pharmaceutical drugs that, especially lately, these opioid epidemic that we've been seeing. A lot of people overdosing on newer and newer forms of more potent forms of opioids or painkillers. So that's not a fun way to start our day, but the question is, this is potentially an example of too much healthcare being dangerous. So we said, oh, we're not treating pain enough around 2000, and we decided to give more opioids, and then 10 years later we have an epidemic with a lot of people addicted to opioids, and you can actually see that in the mortality rates of middle-aged men and women. So I tried to go through ways of measuring returns to healthcare, sort of crude ways, life expectancy or across time or across country. But what I do mostly in my research is trying to come up with ways of using large data sets to figure out where there is value in healthcare and where there's potentially waste. So one idea, and I hear this at MIT a lot from my engineering friends, is that we should let the data speak. We should just look at the data and figure out where the gains to healthcare are. And here's a chief data scientist in the United States letting some data speak. He's holding up a graph of the U.S. home ownership rate and showing that it's gone down during the election. He was saying that this up and down was due to policies of the previous administration. There are probably other reasons for this. Maybe the Great Recession would be a good explanation. But the point here is that using data is an extremely powerful tool. Even simple data sets can help you convince people of an argument. So that also puts the onus on us to make sure that people are interpreting data in a reasonable way. So let's put it a little bit better terms for the previous administration. U.S. unemployment has a similar up and down. And you could point to that and say that's due to President Obama's policies. But just like the home ownership rate, I was sort of skeptical whether that was Obama policy or not. I'm a little skeptical about this one. And so the blue line I've drawn here is what we call, here's the vocabulary word for those of you not in data science, would be counterfactual. So counterfactual is what would have happened. So let's say there were some policies that came in 2009-10 that led to the unemployment rate to fall down. Well, if there were a different set of policies, we'd have a counterfactual. What would have happened under a different set of policies? Let's say President Obama was not elected and there was a different president, President Romney. So the question is, that orange line looks pretty good. Unemployment rate came down, but it could have come down even better depending on what would have happened under alternative policies. Alternatively, the Democratic administration said they prevented the next Great Depression. And they said that the counterfactual, what would have happened without their policies, is a skyrocketing of unemployment. In order to interpret whether the policies did a good job, you need to know what the counterfactual is, what would have happened. And that's not always easy to do. So that's what I tried to do with data. I tried to predict what would have happened under a different set of policies. So how do we go about doing that? Let's put it in terms of health for the purpose of today's talk. On the y-axis there, the vertical axis, I have mortality. And on the x-axis, I have treatment intensity. So I'm trying to estimate a relationship between how much do we treat someone, how much money do we spend, or how many labor hours of doctor and nurse time do we devote to someone who got sick. And I want to estimate a relationship, something like this. If you treat people more, do you get lower mortality? And what is the speed of that decline? And then we can try to start to think about whether it's worth it, especially if we have scarce, limited budgets of resources like time of doctors and nurses. Where should we devote that time? So here's, I'm going to show you some data for people who had a heart attack in Florida. This is from one of the papers I wrote a while ago. The y-axis is whether they survived their heart attack within 30 days. And the x-axis is how much we spent on them in the United States, how much payers, like private insurers or public insurers, paid for their care. And so remember, I'm trying to estimate this relationship between if we spend more on you, do we lower your mortality? And if you look at the data, it just doesn't look that way. If we spend more on you, it actually looks like it would increase your mortality. It's going to be very hard, no matter how fancy you get with your statistics, to fit a downward sloping curve to that scatter plot. So one answer could be, well, we should spend $1,000 on every heart attack patient and dramatically lower mortality. And obviously that's not going to be the case. This is sort of a cliche now, correlation isn't causality. And so clearly if you have a heart attack where they're not spending very much on you, you probably had a mild heart attack. If they're spending $40,000 on you after a heart attack, you had a major heart attack. And so it's not that spending kills you, it's that if you're being killed by the heart attack, if you have a more severe heart attack, we're spending more on you. So the causality just likely goes the other way. So should we let the data speak? It's hard to let the data, this data is not speaking to me. So we have to find other ways to let data speak to get more credible answers. So just to wrap up this point, the correlations can be misleading. Treatment is a choice. We choose how much healthcare to give people. And if we choose to give more, it's likely because they were in worse health. And so then it's going to give you these spurious correlations. So one way that you can get at the counterfactual are randomized experiments in healthcare delivery. So a lot of what I do now is I work with large healthcare providers or insurers to run randomized experiments for different ways that we can treat people. I'll give you some examples. So first, it's sort of the vanguard of management today is to use more randomized experiments to figure out what works and what doesn't. Google runs about, last I checked, I think it's 15,000 experiments a year. Every day when your eyeballs are looking at Google, you may be part of one of their experiments where they've changed some feature of Google and they're measuring whether you click on an ad or whether you click on the first entry of a search. They're trying to improve their performance by running tens of thousands of randomized experiments every year, and you see that Amazon or banking or Uber. So I work at MIT at the Sloan School. We have an initiative for health systems innovation where we have support for these types of experiments, and the JPAL, which is the Poverty Action Lab at MIT. Take my time. So at JPAL, we have about 700 ongoing randomized trials across 67 countries. Sorry, this figure's a little bit small for you in the back, but we have many experiments across the globe looking at how do you alleviate poverty, essentially. There are lots of programs from microfinance to healthcare interventions. About 150 are healthcare projects that we have going. And the policy themes that we come up with for health are just 6. And I'll go through one of them in detail because I don't have time to go through all of them. But one is that pricing preventative healthcare products to increase adoption. It turns out that price is a very big barrier to adopting what we would think are home run type of technologies in healthcare. Another one would be, and economists like to think about these things, incentives. That would be financial or social incentives or nudges. Do you make it easy to do the right thing? I think of nudges that way, that changing the way we deliver healthcare to make it easy for people to do the right thing, where the right thing is the most efficient or the most valuable way to go about delivering healthcare. Information campaigns, we could test how do you provide information to people to make them learn what we want people to learn and actually behave the way would be beneficial for their health. Interventions to improve healthcare provider job performance, so we could randomize how do we deliver healthcare and how do we organize teams to deliver healthcare across the globe. School-based interventions to improve child health outcomes. This is one of the big success stories in JPAL, the Poverty Action Lab at MIT, is that they did large-scale randomized assignment of deworming drugs at different schools. And so these drugs dramatically were inexpensive, and they dramatically improved the health of students, but also improved their educational outcomes as well. So when people ask JPAL, what are some of the things that you've learned that we should do more of, deworming comes in as something that has a very high return to healthcare. It's not that expensive, and it has large gains in terms of health. And then interventions to improve early childhood development. So basically, after a mother comes home with a newborn, how do we deliver care? There have been many randomized experiments showing that this postpartum interventions can have very big impacts on kids' lives, not only when they're little, but as they grow. I'll just talk about one theme, which is pricing preventative healthcare. So if you give free care, that would lower the hurdle of people getting it, obviously. It would inform people about the benefits because they get to try it for free. And then externality. So externality is when you have a benefit or cost on other people that you don't benefit from yourself. So when there are large externalities, like if I don't get sick, then I don't spread it to other people, there's a role for trying to nudge people toward getting this preventative health care. But what if you charge for care? Maybe that would have benefits as well. So paying for goods might make people more likely to use them. There's a concern that if you give people free things, then they're not going to value them. It would be more sustainable if you could charge money for them, because otherwise we have to raise money from other sources. And you could avoid take-up by those who don't need it, what economists would call moral hazard. So if you give people it for free, you're not really screening on who really would benefit or who would use it. Okay, so then what we do is we have randomized experiments where we try to figure this out. So if you have a group that you've randomized that are charge 60 cents for insecticide-treated bed net versus giving it away for free, demand falls by 60 percentage points. You basically, if you give it away for free, almost everybody would take one. If you make charge just 60 cents or 10% of the price, of the actual price, then it falls, less than 40% of people are taking it. And similarly, we have lots of examples like this. Here's just a graph. These downward sloping lines show that it's on the x-axis is if you increase the price from 50 cents to $1, $1.50 for the treatment, the y-axis is take-up. So if it's free, you see many things in the 60% to 100% take-up. But as you get to $2 for bed nets or slippers, you see going dramatically down to 30% will take it for a very subsidized price still, but it's not free. So there's something special about being free. But what we've learned as well, not only do we learn, and this may have been intuitive to you, that if we charge money, people are going to use it less, maybe we'd learn how much less, but we also learned that cost sharing does not appear to concentrate the take-up among those who use the products the most, that the people who get it for free use it among these types of interventions that we were looking at, like bed nets to prevent mosquito bites or slippers to prevent worm infestation. And there's no evidence that the act of paying for a product makes a recipient more likely to use it. So there's, and when we do this, there was evidence for it, but these were more observational studies. Once we go to the randomized experiment, where we get an estimate of that counterfactual, what would have happened if they paid for it? Now we know what would have happened because we've randomized. Some people pay for it, some people don't, and then we can estimate that counterfactual, what would have happened, and we find out that it doesn't, when people pay for it, it doesn't make them more likely to use it or treat it more carefully. So some things that we've learned at JPAL, one would be to subsidize these user fees for key preventative healthcare products. This is the argument I just made. The other three ones that I've mentioned, number 3 is school-based deworming. Number 2 is campaigns with sufficiently specific and actionable information. When you have information that you're sending to people, if it's broad warnings about something's dangerous, it doesn't seem to work as well as if you say you should do something to prevent the danger. And then community agents supporting parents to provide this postpartum interventions that stimulates children. Looks like it has very long-lasting and dramatic effects on educational attainment and other benefits to kids and their health. So some of the trials I'm doing here at MIT, and maybe if we have time to talk about them in the breaks, I'm happy to talk, but one is hotspotting. So here, 5% of people in the US, and this is similar in other countries, 5% of people account for half of healthcare spending. If you get very sick, it's expensive to treat you, and only 5% of people are accounting for half of the spending. So one idea is that you should figure out who those expensive people are and treat them in a new way. So in the Camden Coalition of Healthcare Providers, this is a low-income city in outside of Philadelphia, they decided to find out who the most expensive patients are and treat not only the clinical needs of patients, but their social needs as well. Getting people housing, getting people proper nutrition, getting them transportation to their doctor's appointments. And so this idea of treating the social determinants of health is a very hot idea in healthcare. And so what we've done, though, is this is a very lauded program. People think this is a great idea. And they've partnered with MIT to randomize people into their program or not into their program so that we can have an estimate of that counterfactual. What would have happened? if they weren't part of this program. And so in the fall, we'll be coming out with a paper discussing what the impact is on the patient's health if they got into this program or they were randomized into a control group. I'm doing a study of physician-provider ordering of CT scans and MRI images. When they go ahead and order one, there could be what's called clinical decision support. So this is aids in the computer that when you're ordering something, based on the computer records of what the patient might need and what the doctor says that he or she wants, the computer will say, you want this, but have you thought about these other things that are, according to guidelines, actually even better? What's nice about this project is it's a provider-level randomization. We've randomized some physicians are exposed to this and some are not. And Medicare, which is the essentially free healthcare for people over the age of 65, universal healthcare for people over the age of 65 in the US, they are mandating that any of these kind of images, if they won't be paid for by Medicare next year if they don't go through this type of clinical decision support, despite much evidence of whether they work or not. So here, we're going to provide the most rigorous evidence of whether the program works by randomizing some physicians seeing it and some not. And then I mentioned the opioid crisis. I'm doing some randomized controlled trials in opioid treatment, especially when people leave the hospital on high doses of opioids. We're randomizing some of those patients will have access to specialists to treat their pain, to manage their pain, and other ones will get the usual care. And by randomizing some people into the control group, again, we'll be able to estimate that counterfactual, what would have happened if they were treated by a specialist. Now we'll be able to say. And then last, one of the projects I'm most interested in, because I'm actively going to roll it out this fall, is prescribing fresh food to low-income diabetics. So these low-income diabetics in Pennsylvania are prescribed fresh food. The doctor writes down you have a prescription for fresh food, and then they come and fill their prescription at a clinic every week. They get groceries for themselves and their family for the week. And it takes away some of the stigma of going to a food bank, say, and getting food, charity care, because you're getting it from your doctor, getting it from your healthcare provider. And there's large take-up of this type of program. People like it, but there's a lot of, this is again addressing a social determinant of health. So there's so much excitement about this program, but there's not much rigorous evidence on whether it works or not. So they're expanding into 2 new cities, and as part of that expansion, they partnered with MIT to randomize who gets to be the new clients of the program. So some people will get it now, some people will get it in 6 months. We're randomizing who's getting it first. And then we'll be able to tell the counterfactual, what would have happened if they got the program. We'll look at compare the treatment and the control group to get that valid comparison. Now there's a limit to randomization, and the classic limitation is what we call internal validity versus external validity. So I'm confident at the end of the day when I look at this program in Pennsylvania, I'll have a very credible estimate of whether that program works in Pennsylvania with those patients. But then the question is, does it work in California? Does it work in Lucca? And so that would be external validity. Are the situations similar enough in Lucca that a program that works in Pennsylvania would work here? And so you can look at some things. How similar are the patients in terms of their blood sugar levels? What type of diets do they have already? But ideally, we would have, any time that a new program like this starts, there would be an eye toward evaluation. So if you're expanding a large program, you could just do it in an ad hoc way, or you could do it with a true randomization so that you get a credible estimate of what you're doing is working. I feel like we do a lot of new initiatives in healthcare, and we feel like we're doing something good, but we're not sure. And we're kind of chasing our tail and trying to improve things, whereas if we could have more experiments, we would be slowly ratcheting up our information set of what works and what doesn't. If I found out that this program worked in California, Pennsylvania, Italy, and Japan, then I would become more confident that this is a type of thing with low-income diabetics that they all respond in a similar way to giving them fresh food. If it works in some places but not others, then we would learn about why it might work in some places and not others. And economists like to model why people make decisions. And so ultimately, we would like to look at how do people get into the habit of eating salad? This is kind of an interesting, how did you get into a habit of eating salad? I give my kids salad every night, hoping to build their habit of eating salad. So one of the projects after this initial one will be to not take food insecure, not take low-income folks, but middle income, and randomize how long do you give fresh food to people before they change their habits and actually start eating fresh food on their own when they have to pay for it themselves. So do you give it for 3 months, 6 months, 9 months, and then look 18 months later and see how much better was it to give it to people for 12 months than it was for 3 months in terms of their eating better at 18 or 24 months? How do people change their habits? It's a very interesting question and one that we need to learn if we're going to address these social determinants of health. Okay, I don't want to take up all the time, so I'm just going to go quickly. Without randomized experiments, there's a lot of hope that we can get to causality. In other words, comparing the counterfactual, what would have happened with what actually did, with quote-unquote big data. So what do we mean by big data? We've all heard big data is a lot of data, obviously, but also different types of data, unstructured data. So if we want to measure whether this fellow is getting healthier, you might want to observe how quickly he goes up the steps every night when he goes to bed. Right now we have no hope of estimating that, but if we have this high-tech device called his cell phone, if he has a cell phone on him, we can actually see how fast does he ascend stairs. And there are obviously privacy issues and a lot of hurdles to overcome, but there's a great hope that there's a wave of data coming so we can measure what works and what doesn't, and ideally get a way to get to causality. So I'll give you an example. In order to get to causality with big data, you could either use a lot of assumptions that are letting the data speak in a way that makes economists less comfortable, or you could look for what's called natural experiments, something that mimics a randomized controlled trial but happens naturally. So these require great data, which we're getting more and more of, but also institutional details like policy changes or treatment rules. So I'll give you an example of one that I've worked on. Consider the birth weight distribution in the United States. Luckily, these are in grams, so you guys will understand it better than I will. But we have this, Gaussian or normal distribution of birth weight. And if you look down at 1,500 grams, if you're born below 1,500 grams, you're categorized as what we call very low birth weight, very low birth weight. If you're under 2,500 grams, you're what's called low birth weight. It turns out that neonatology manuals recommend more care, different types of care, if you fall into some of those categories. And what's nice about this is what we can do is look at right around that 1,500 gram threshold with lots of data. We can compare people above and below 1,500 grams. And this first graph is showing you that on their predicted mortality, based on how long their gestational age was, the education of the parents, lots of correlates with how healthy people are. It just doesn't matter whether you're born at below 1,500 grams or above 1,500 grams, how healthy you are. Does that make sense to everyone? If you're 1,501 grams or 1,499 grams, you're basically the same level of health. But what's nice is the next graph shows that if you go from the right to the left, as you get lighter and lighter, from 1,650 toward 1,500, we're spending more and more on you. About $85,000 for people just above 1,500 grams. But as you cross the threshold, you see this discrete jump in how much we spent. It goes from 85,000 to 95,000. So it's not like we don't spend much on 1,501 gram newborns and a lot on 1,499, but you get this meaningful variation, a jump in how much we spend on newborns. And if you look at 1 year mortality, do these newborns survive to 1 year? Again, you can see that as we get lighter, the mortality rate is rising, but then it falls down. It goes against the trend if you cross the 1,500 gram threshold. It's going up, 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 and then it goes down, and then up, 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 up. And so if the newborns are very similar in terms of how healthy they are, it's like an experiment. Because one group got extra care, one group got less care, but they're very similar to each other because they just happened to cross the threshold in terms of this arbitrary round number in the metric system of 1,500 grams. So we can use that type of variation to then estimate, was that extra care worth it or not? And we argue in the paper that it's an extremely inexpensive way to save lives by providing more care to these 1,499, or more care to the 1,501 gram newborns. It's clearly, from our estimates, worth it, this extra spending, because it's a very inexpensive way to save lives. Then it was replicated in Chile, so not just in the US. And then Chile, they also looked at educational outcomes like test scores. These are newborns, 12 years ago, born just above and below 1,500 grams. And then you look at them 12 years later when they're getting their math scores, and you still see that if you're born at 1499, you do better than if you were born at 1501. This was replicated in Norway, so this gets to the internal and external validity argument. With lots of data from lots of places, you start to get a better sense of external validity. It's been found in Chile, Norway, United States, Denmark. We keep finding that doctors respond to these thresholds and that the kids are doing better, the newborns are doing better if they got extra care. So it's starting to sink in, I think, that we should be treating these newborns at a higher rate. There's a return to that. And here's an example I like to finish on with these type of comparisons. This is the age of people on the x-axis, and the y-axis is here. Oh well, I'm better at the US keyboards. I'll explain it. So the top line is, you could hopefully see these dots are going down and then there's a jump up. The dots are the mortality rate by each month of age. And the ages go from 19 to 23. So it's going down, down, down. The mortality rate on the top is motor vehicle accidents. So you see the mortality rate from motor vehicle accidents is falling as people get better at driving and a little bit more mature as they go from 19 down to 21. But as soon as they turn 21, the mortality rate jumps for motor vehicle accidents. And that's because in the US, you can drink publicly at bars when you turn 21. So you can drink publicly, that means you can go out and you can unfortunately drive after drinking. And so when I give talks to students, I say, don't drink and drive, only get you so far. But similar to the data scientist Donald Trump before, if you show data, it can be convincing. And here, there's really nothing different between if you're just turned 21 and just before 21 in terms of your driving ability or getting a job or graduating. It's that you can drink publicly now. And so this is, to me, not only showing data of a downward sloping line, but a story that you can say, we know what the counterfactual is. What would have happened if these 21-year-olds weren't allowed to drink? There would be a lower mortality. And so whether we're going to prevent drinking, change the drinking age is one thing, but does drinking and driving, how dangerous is that? You can just see it in the data. And I think that can be particularly convincing. All right, so I don't want to take more time, but what I want you to take away is that this healthcare, there's this huge value potential. Economists estimate these huge dollar amounts to be willing to spend. But it also has the potential to bankrupt us, because if we come up with a new drug that costs $1 million to treat something, people who have that disease, they want to spend the $1 million, or they want the government to spend the $1 million. So it has the potential to bankrupt us as well. So we need to credibly show the value of where there's waste and where there's value, at least to get a start on where we should be spending our valuable dollars or euros. And so we can get that from randomized experiments and natural experiments as a way economists like to think about how do you get to say something causal from these large data sets that we increasingly have. All right, I think I'll stop there. I'll take a couple questions. Is that okay? And then if you guys have any questions, I'm happy to take them now, or we can talk about at the end.
So is there any question by the audience? Armando.
Reduce the problem of U.S. spending mostly from the consumer point of view, the problem of the demand. What about the supply side? How organization of production is different from Europe, where we are able to contain costs? There's possibility that companies in U.S. they can price innovative drugs higher with respect to Europe. Maybe there's a problem in the oligopolistic markets that you have in U.S.
That's right, yeah. So I didn't get into the fine details of why we spend so much more. One idea I said was our plates are bigger. Literally, our plates are big. We have a lot of food in the United States. But then there's the supply side as well. So prices are higher in the U.S. We pay more for drugs, but we also pay more for labor. And then there's a question, is it worth it? So what if we reduce the salaries of doctors? What if we lowered the price of drugs? then you'd be concerned about, well, who becomes doctors and what kind of drugs get developed. So these are hard to answer questions of what would really happen if we slashed our spending on drugs. How much slower would innovation be as funding goes away from healthcare toward other research projects, other investments? But we know that some of that would happen. And so that's where we have to get into estimating, is it worth it to be spending so much on healthcare? Now, there's no doubt that there are inefficiencies in the US healthcare system, a lot of redundancy because of the multiple payers and so on. We could get rid of some of that. But one thing I'd like to point, Medicare is the free care for people over the age of 65. It's very cheap in terms of their administrative costs, similar to other countries actually. But they don't do a lot of restraining of what people spend. They basically write checks. Whereas health insurers, they try to find out, is that extra test you're getting actually valuable or not, and they'll only pay for it if they think it's valuable. And so then obviously patients and doctors don't like being told no. But if we're spending 20% of GDP and we want to get that down to 18 or 17, you have to start saying no. If our public agencies always say yes and just write checks, then we won't be able to get there. If they're negotiating with drug companies to have lower prices, then you can see where they have immediate savings. And we'd be worried about, does that slow innovation or not? But I think Massimo will talk directly about things like that.
Okay, any more question? Seems no.
Okay, thanks very much.
I have one myself, but it's about, it's on the slide. You mentioned randomized trial, and there's now a trend toward accelerated approvals. So more frequently, clinical trials are by definition sort of randomized control experiments, but more frequently you sort of move randomized experiments, meaning clinical trials, to the real world. And maybe you can comment and tell what is the US experience about that. So how frequently the FDA approves trials to be run in the real world instead of being in the lab or in a controlled clinical setting.
Right, so in order to approve drugs, we have clinical trials to see how efficacious they are and whether they're dangerous. And then there are stage 1, 2, and 3. They get more expensive as you go, and you need to have stage 3 approval in order to sell drugs. Then there's stage 4, which is in the real world what happens. And my understanding is that there's a lot of rhetoric and discussion of we should have more of this, but there's precious little of it. That the pharmaceutical companies have a very big incentive to get through stage 3, but not so much into stage 4, which is in the real world. And I think that this lends itself to the natural experiment approach, though, because if you can find ways to compare people who have access to new drugs, because of the way that their physicians are more prone to adopt newer technologies, for example, we can start to come up with, we have tools in economics and econometrics to tease out this counterfactual. So one example would be, there was a new drug that was developed in North Carolina, and if you look at the adoption of this drug after it gets approval from the Food and Drug Administration, it's quite high in North Carolina, and then it spreads out to the neighboring states, and it's actually geographic spreading out, like you throw a pebble in a pond. So if you see that the treatment effects, that people get healthier in the same way that the pebble went, that the wave went out, as the way the diffusion of the technology went out, you could start to get some credible evidence in a real-world, large data set setting that the drug was actually effective. So that's the type of idea where you can use large data sets to get these natural experiments to help you, where we don't have clinical trials every moment of every day.
Okay, thank you very much.
Thanks very much.
Yeah. And next speaker, Professor Sabina Nuti.
Okay, so good morning to everybody, and thank you to Professor Pietrini and Professor Riccaboni that invited me today. It's a big honor to be here to share some of the Italian evidence and data. Makes the data speak, and who is in the room and knows me I think everybody knows that we try to do of this sentence the mission of what the MES lab is doing in Sant'Anna. So my presentation will be regarding what is the state of the art of this theme, measuring performance in Italy, especially presenting the experience that we are carrying out with some regions. First of all, just a few elements on the Italian system. Everybody knows it, but just to remember altogether, we have a beverage, we adopt a beverage-like model, universal coverage, almost free at the point of care, financed by general taxation. And the organization is divided in three levels. The national level that's responsible really of equity and general responsibility, but who is really in charge of healthcare in Italy are the regions. We have a federal system and they are in charge of organizing and providing care. And as Professor Pietrini was saying, the healthcare system is around 80–90% of the global budget. So you can imagine in Italy, we lose the regional election if we don't have good results in healthcare. And then the local level, that's organized with local health authorities that are in charge, and most of the region also of hospital care. We still have some autonomous hospitals, especially for the university hospitals, but they are inside the regional system. They are contracted for the type of care they deliver. Of course, this is more or less the situation of all the Italian region, a little bit different is Lombardy, that has a system that starts from a tradition of splitting providers from local health authorities, but is going backwards from this decision. The last 2 years really did a big change and got back the hospital, most of the hospital, inside the local health authority. So we say that we are going towards quite a common way of organizing care in the Italian regions. I am part of the independent expert group for the European Commission, and I'm so sometimes discussing with my colleagues at the European level regarding the situation of Italy. This is the data that you already showed before, and this is the OECD health statistics and what is the percentage on the GDP. And as you see, we are not a very strong country from the point of view of spending. We don't spend a lot on healthcare. But on the other side, I would like to start with this beautiful paper that was published in Lancet in 2017 that shows what is the situation of the healthcare system considering this healthcare access and quality index that considers the mortality for 32 pathologies where the healthcare system can really do the difference. So there are some specific needs where if the healthcare system is timely and appropriate, you can really do the difference in the mortality rate. This very large group of epidemiologists worked through the data from 1992 to 2015, so 25 years, and these are the results. You see what was the situation in Europe and in all the world in 1090 and what happened after 25 years, and you see that Italy, here we are, became much better. And if we look at the ranking, the situation in 2015 of Italy is the 12th country, and we have a lot of European countries like Germany, like France, that are under our position. I say this because usually in Italy we always think we are not as good as we are. And so I thought that sometimes we have to use the international data to have more courage and to be more proud of our system, because with how much we spend and what are the outcomes that we take home, I think we really do a very good job. And this is the frontier. So considering the results and what is the average personal income with education and with birth rate, you see that Italy is on the frontier, and so has a very good result considering the type of efforts that is put there to achieve these results in healthcare. So this is the starting point. Let's see what's going on in Italy and what have changed really a lot in the last 20 years. When I started to work in healthcare, we had a lot of planning tools, but very little regarding measurement. As in all Latin countries, we speak a lot. We discuss a lot. What we say in Italy, we have a word that's concertazione. We share. We had very little data. This really changed in the last 15 years, and the data that are available now in Italy are really a lot. My research group works on these three words: performance, healthcare, and improvement. How can we improve? And how can we improve the concept that you very well explain of considering the value that's provided and the money that we put there to achieve this value? Let's start from what are the main goals of our healthcare system, as usually: quality of care, financial sustainability, this is true in all over the world, and then being a universal coverage system, the concept of equity that for us is really relevant. And when we speak of equity, thinking from a measurement point of view, we should consider in two different perspectives. On one side, are we able to do the difference? So if we have some patient starting with a lower education, or for example, different from a gender point of view or ethnia, are we able to do the difference and provide different care, different services, considering the starting point? But the second big challenge is also the horizontal equity, and we mean for this, are we sure that when we have the same needs, we are able to provide the same level of care? These are the two big goals that, together with quality of care and financial sustainability, are in our healthcare system at the regional and national level. Now, when we speak about value for money, from the management perspective, I think that everybody in the room has the idea of what is the concept that Michael Porter provided in the first place, saying, well, when we speak about value, we should think of what are the outcomes that the patient takes home with the money that is spent for this care. And then, thanks to Beric, we started to think in a more large perspective, and we said, well, we just don't have to consider only the patient, single patient experience, individual patient experience, but we should consider the population perspective. And last of all, I would like to remember this beautiful article of last year of Muir Gray that says, look, if we really want to achieve equity and think in a population perspective, we should stop thinking how to improve care considering the patient we are caring for, but we should consider on the other side the patients, the people who could more benefit from care and that perhaps we are not serving. So we create population value and how much we are able to provide care to those that really could benefit more of care. And this is something that I think should be inside our performance evaluation system. So when you were saying how can we avoid inappropriate care, how can we avoid waste, if we are able to concentrate our attention to provide care to a person that really needs it. So you can't just think that it's enough that each hospital looks at its patients and try to improve what the care and the services they are providing. It's not enough. Specialists in the hospital have to put their nose outside of the hospital and try to think who is out there that needs care, is not cared, and if there's somebody in the hospital that shouldn't be there. So in a way, this is what I mean for adopting a population perspective. Now, if we go and see what what it's out there in the literature regarding which are the healthcare systems that are able to achieve more results, putting these three elements, quality, equity, and financial sustainability. I like this paper of Brown and colleagues that say, look, if we go and see results that are evidence-based, we see that the systems that have achieved these type of goals usually consider these 3 points, common elements. First, a public specific statement of goals of improvement and a plan for reaching these goals. You have to be very clear and have specific goals. It's not enough to have, and this is for the Italian people here, a big strategic regional plan of 300 pages. That's not having clear goals. You have to reduce and be very practical in a way. You need public disclosure of data. And these have to be, of course, with these quantitative elements linked to the strategy that you want to carry out. And third point, having a strong process of engagement with physicians, with specialists, with the GPs, with all the health professionals that are involved in care. This is something that really makes it different. Well, with this type of premises, what did Italy do regarding performance evaluation system? Well, we have 2 systems, one at a national level and one at a regional level, considering the different type of responsibility that the Minister of Health has and the region have. At the national level, the government in these last years put in place 2 main type of tools. The first one, it's about a certain number of indicators every year. You have a little change on these indicators that want to measure what are called the essential levels of care. That means the standards under which the regions and the providers can't go. So trying with an approach with a bottom-up pressure and trying to improve these essential level of care every year. And on the other side, from 2010, we have this large program of outcome measures that is carried out by Agenas that allows us to have a really very large number of indicators regarding outcomes, especially hospital outcomes. Why hospital outcomes? Because from a national point of view are the only data that we will have an improvement next year, but until now, the only data that are sufficiently rigorous to have this type of risk adjustment process, to have good data. They're all public disclosure. Every citizen, every specialist can go through and see these data. From a regional point of view, the idea is, of course, to have another group of tools, starting from the idea that if you want really to achieve improvement, on one side, of course, you need to have what we call a push system from the bottom, so the national level, that ask regions and providers not to have holes in their healthcare system. But on the other side, you need also systems that put in place tools that help providers and health professionals to be engaged in an improvement process. So I would call these tools pool systems that work much more on motivation and engagement of health professionals. Let's see what's there from a regional point of view, and of course I will tell you something about our experience. The experience of the Scuola Sant'Anna is that since 2004, before in Tuscany and then from 2008 with other Italian regions, we've put in place what is called the Interregional Performance Evaluation System. Also, this system is on a platform, and since the 1st of June 2017, we already have the data, we already have the data of the year before. So it's a very timely, prompt system that puts together the data of 10 regions and 2 provinces that on a voluntary basis, and this is very important, decided to share their own data. So the basic elements of the system is that all the informations are measured in benchmarking among these regions. It's on a voluntary basis, and this is really relevant because it's something to do with the honor and the dignity of the regions and of the providers that are afraid of publishing data and to try on this basis to improve. We avoid the synthetic ranking where we put all the data together for the hospital because this is really unuseful. So we don't like very much what the minister does, that puts the data of the essential level of care in a single number, because it doesn't mean anything to know that the Tuscany region is 2012. What does it mean? You want to know in the single indicators what is the performance and what is going well and what is going wrong. So the region decided not to do the ranking summarizing all the indicators, but having different indicators spread out in public disclosure on a voluntary basis with data and with a public university that it's guaranteeing, this is Sant'Anna, this benchmarking process. And we work really a lot also with professionals to share our evidence. And we help the regions to set challenging goals and priorities of strategy on the base of data. And of course, considering that we have this very important goal of equity, one of the main goals is reducing avoidable variation. The system, it's a very large system. We now share among the regions about 300 indicators, and around 140 of these indicators are performance indicators, and the mean that they are evaluated with performance bands that are based on international standards and or on the average or on the medium of the region participating. 5 performance band with the colors. And I just stop a second to say that this is really important. We did a lot of experimental random, we worked a lot, and we have a lot of data on this to see how important are colors in communicating results, because one of the big issue here is to make the different stakeholders understand the same language. We have policymakers, we have citizens, we have health professionals, each are different type of culture. We need them to use the same language. And colors is really relevant, especially with our policymakers. Red is bad, green is good. And this is really important, considering that sometimes health counselors and politicians arrive to decide relevant decisions for healthcare, and they don't have a background. And so we need very quickly to make them understand what is relevant. This is the way we do the evaluation, and this is the way we present our data. So the regions, the trend, the local health authorities, and the geographic map. For example, the cesarean section deliveries to see who's good and who's bad. And you see these are different regions. So these are, for example, our tonsillectomy. This is different regions. And as you see, the truth is not just that the south is different from the north. The truth is that within each region, we have a lot of avoidable variation. A lot of avoidable variation. Then, of course, if we look at Tuscany and Veneto region, perhaps we can say that in the average they are better, but there is still a lot of work to do also in these regions. How we present the data? With the dartboard. And I'm happy to share the idea that we also did this natural randomized experiment. Just this year, we did the organizational climate survey with health professionals in Lombardy. 100,000 of people were involved. And we asked to the head of the department, the clinical head of the department, we did this experiment showing them the data of clinical path in 3 different ways, with the spider net, with the dartboard, and you will see after with the stave. And we asked them from a subject in an objective way, after leaving them 2 minutes, the data there, what they understand about the picture and what are the lessons they learned from this different way of seeing the data. And we were very happy to find out that the dartboard has a really different impact, considering the spider net that is usually used in the management way of presenting data. And the stave even more, and I will see it later. So we present the data in this way, and I show you very quickly the way that we presented the data in Venice just last week. This is Basilicata, just to give you an idea. The more the points are at the center, the better it is. The more they're far, it's a week. These data are the same that you saw in the before in presenting results. So you can get in an interactive way from the platform, you can get on each dot and see the data presented as you saw before. This is Basilicata, and then we have a performance map where we go and see if the main indicators have improved or are decreased, and of course, everything is measured on a benchmarking system. So this is Basilicata, this is Bolzano, and this is the map of Bolzano. This is Friuli, and so on. I go very quickly, but I think that you can see just looking how much is, this is Lombardy. You see Lombardy has improved much more than the other regions. You have all the top part of the map is much more, with more points than the back. The Mark is not a very good region. Tuscany, very good region, where we are working with this measurement system from a lot of years, so we have something to say, even if this year we have, for the first time, some indicators not increasing, not improving. This is Trento, and I go quickly, Umbria, and this is Veneto, one of our best regions, and this is the performance map of Veneto. So what have we learned from this system? And we tried this natural experiment in Italy, looking also the regions that were adopting the system, the one that were not adopting this region. And what comes out from the paper that we published is that this type of system works a lot, considering especially the capacity of improve. The national level did a lot, especially to make all the region achieve a minimum level of care. For example, one of the most relevant indicators that we have is the capacity to operate a femur fraction within 2 days. We started with 30% at the national level, a very low performance at the international level. We now achieved the 60%, and most of the regions are in our network already around 80%. So the national level, with the approach of, in a way, an expective approach, I will come and see what happens if you're not able to achieve that, that goal. And, and I can also go around the region and go directly to the hospital if you don't achieve that specific the level of standard, helped to push from the bottom, the low care, and to have it improved. On the other side, public disclosure and discussing data with health professionals really helped, based on reputation process, to improve in the regions that have adopted the AIFAs. This, for example, is the results of Tuscany from 2008 to 2016. And what is really important is not just the trend, but the capacity of reduce avoidable variation among the providers of the regions that you see in the second graph. Now, the question is, are we creating value? Well, of course, if we speak about financial sustainability and we look at this data that compares the health expenditure and amenable mortality, of course, who spends less has more problems in Italy. And this is quite clear if you look at this type of, so in a way, if in this room will be all our politicians, I would say, please spend more on health, because it's a good investment. It's a good investment. Yet if we go inside the system, there's no doubt that if we work with more quality, we can surely avoid waste and have more value for the money that we spend. So these are the data of the IRPES. Every year we have this type of data. You were right, correlation is not causality, but yet what we can see here, considering the per capita cost in euro for our local health authorities that are inside the network of the regions and the global performance, we see that who spends more surely doesn't have a better performance. This is quite clear. So in a way, I have your same opinion that we need to go deep and see the way that we can spend in the best way the money that we have, especially improving quality of care. What is the work we've done from this point of view? We think that the way of having more value for the money we spend is going above the silos perspective, because this is something that really creates waste. And I will tell you a little story about this, how we are working on this. On our performance evaluation system, we have a famous indicator that is the number of amputation for diabetic foot. And Italy is a very good performer in the European context, and Tuscany is one of the best regions. But we had an incredible avoidable variation in Tuscany. And the problem was that one of the worst performers some years ago, this is Pisa, where was the place where that was the referral center for all Tuscany for diabetic foot. So this was quite strange. The place where everybody, all the clinicians go and study to become good specialists, have the worst performance on amputation rate for habitants. So the Pisa people could have 6 times the rate of people living in Arezzo. So this created big problems, you know. We wrote this very nice paper, I think, about this story. This was the situation. In Arezzo, we had this nice lady there, that Dottoressa Ricci, that was doing a job, and nobody knew what she was doing really before this big experience. On the other side, Alberto Piaggesi, that's a really very good specialist in our teaching hospital in Pisa. At the beginning, he was saying, my cases are more complex, and because I'm a referral center, so I have more amputation because they come to my hospital, and we needed some months to make all the clinicians understand that we were working on population data. And there was not his patients, but there was the rate of residents, because this is not easy as a message to go through. And discussing and working all together with all the diabetics, we start mapping what was at the back of that data. And here is the rates, but divided on considering the different providers, who was providing that care, and what was at the back of the process. And we find out that what was happening there is that was all the path that was not working. And GPs were thinking that it was a responsibility of the hospital because it was a referral center. So nobody was looking at the feet of these diabetic patients because they were not their duty. And of course, the teaching hospital was accepting the patient when they're arriving in the emergency care. And so they were treating them when they were already very severe and so on. And also inside the hospital, lots of problems because the path was not clear. I have here the clinical director of the teaching hospital, and perhaps she could also say something more about the story. Well, a lot of elements that was showing that the problem was the silos perspective. Everybody was looking at the little piece of care, and nobody had the picture. So, working with all together, we found out everything was not working to improve it, and we also look at cost for habitants. As you see, really Arezzo, it's this one, and Pisa had more or less for habitants the same type of impact from a cost point of view for residents for this type of care, but Arezzo was spending much more on revascularization. That it's a procedure that you can use to avoid amputation if you arrive in time. So the idea of how are we spending our money to provide care for a very high impact cost patients. At the end, we were able to find out a regional protocol and to move the situation also for Pisa. And I have to thank specialists like Dr. Piagesi that understood that to improve his own data, he had to go outside in primary care and work together with the GPs. And he did a really incredible job. These are the value, the improvement process he achieved. And if you look at the last 2 years, it's even better. So the idea is to work with a clinical path perspective. We start to present the data in a different way because, of course, you can't say something and then continue to present the data for settings of care. We use now the metaphor of the stave. That seems quite a nice metaphor. We put our data outside of the dartboards and inside this stave, and we had included also the patient perspective with prems and proms. So patient-related outcomes and patient-reported experience. So this is the way we present data now. This, for example, is the maternal health path. You see from the birth, the first years of life, and then after what's happening in the different regions. And it's another way of thinking. And plus, we put with different colors if it's a teaching hospital providing that care or it's the local health authority, just to give the idea that we all work for the same goal. And we can't divide care when you have a clinical path going on. So, no, this is another point, and I would like, I don't know if I still have some time or if better I stop, because the last concept I wanted to give you, because I think this is nice for being here in MIT, is the impact between research activity and outcomes and cost. But perhaps I stop here, and if there are questions, and if you want, I just add also this other little piece.
You can take 5 minutes more.
I can have 5 minutes more? No, because of course I would like to say a lot of things, but most of the people here know the story, so I don't want to bore them. But another piece I thought it was nice from what we've learned is that we have the network of the regions, and then we have the network of the teaching hospital inside the region. We have published a paper in BMJ showing that really the teaching hospitals, the university hospital, are not a cluster. Because inside the group of our teaching hospital, you have more variation than among all the other hospitals of the network. But the issue that they have a special mission, because they have research, training, and care, of course, make them feel a cluster. And so from an improvement point of view, it's very important to help them to have a comparison and a benchmarking with other teaching hospitals. And so we have a network that is just for teaching hospitals, and we compare the data with among these teaching hospitals. And we find out in the last year very intriguing, I would say, evidence measuring the research capacity of these teaching hospitals. And so we start wanted to find out from the evidence that we have what was the relation between research and quality of care. What the type of methods that we used. We are still on the way, and these are the first data. So we still have to confirm them. We would like to have some years more. But we got the data of 17 teaching hospitals. We are still missing the data of the Lombardy ones because we just finished the measurement of their research capacity. But we have already there 17 of these. The year is 2016. And we got all the most relevant indicators regarding performance in care, in quality of care, appropriateness, and efficiency of care. And on the other side, we measured the capacity of research production. What do we do to have this type of measures? We have the names of all the 14,000 of clinicians that work in the university or work in the hospitals. So in the teaching hospital, but they don't have a university career. They're not employed by the university. And we went through all their research production. So we find more than 30,000 publications, and we calculated with research value, that is a spin-off of our research institution at the national level that is very expert in doing this type of measures. We found that we got with these 4 indicators: the average impact factor for physician, the average number of publication, then of course also the percentage of specialties where the teaching hospital were above the international average, and so these two as a medium and as a average. Well, what is the results that came out? What is the relation between performance and research? This is the first data that we have. But this is quite important, I think, for university hospitals, because in a way is to be sure, and we have also all the issue regarding how to train young students inside this teaching hospital, that research is really relevant, not just for having a good result at the university level, number of publications and so on, but saves lives. Because this at the end is what is the message of this type of correlation, or at least it doesn't destroy lives. Because sometimes in Italy you say, well, it's better that you go to a clinician that has a lot of practice, but the researcher can be out there. Well, of course, we can't say this at the individual level, but the institution that has more research, in a way, probably these data says that have even better outcomes. And this is also the number and quality of the research. And then we try to see what's the relation with patient satisfaction. We measure this with the number of patients that leave the hospital against medical advice. We measure this with the attractions. And you see there is still there a good correlation. Financial sustainability, there the cost for DRG point. And so also this is quite relevant considering financial sustainability. Who works in a good research doesn't spend more, and this is very relevant, I think, for policymakers that are very reluctant in spending in research in Italy. And this is another very relevant indicator. That is the correlation among what we say the percentage of productive. We consider a person productive if have published at least one paper in the last 3 years. Of course, a person in the university sector are productive in 95% of the cases. In non-university clinicians is very different. Oh, sorry. The non-academic clinicians, we have a very different percentage in the 17 teaching hospitals. Some of them have 30% of non-academic that are publishing. Some of them achieve 80%. Well, the more non-academic are productive, the more the impact on the capacity of produce research and to have a good performance. In the way that the more there is a team among researchers, university researchers and clinicians, the better is the effect also on performance. So my conclusion is that also I would say research and innovation from this point of view has something to do with performance and the way we are able to manage local health authorities and teaching hospitals, and also the way we put in place governance system at the regional level. I think that these type of data can give also good elements to our policymakers. Of course, what comes out even from a lot of other data that we have is it's really relevant, the level, the capacity of engagement of clinicians and the capacity of working with a team approach, putting together social care, health care, and the different settings of care. Because if we work as a silos, we will waste a lot of money. And last point is I would like to close with the relevance of reputation as the most important tool and mechanism that we have in these type of contexts where we have really high professionals with a lot of capacity, and to work on their motivation. I think we should always work on with motivation, with the reputation issues. Thank you.
Okay, so we have time for some questions. Seems as no question, maybe. I have, since I'm here just to facilitate some discussion, I know Professor Doyle has a paper, and maybe even more than one, the one I've seen, about the quality of physician and outcomes using some randomization. And I think it's sort of relevant to the discussion. Huh?
So one paper that I found to be really interesting, I talked to people about, I want to know, does it matter which doctor treats you for how well you do? Okay, it's a basic question. If we get sick, we want to know, how much does a doctor matter? How much should we be lobbying to get the best doctor? So I was talking to people at a cocktail party about this, and they said, well, I know a place where in the Veterans Administration, so treating veterans, this is free care for veterans, there's a large hospital that's that has two teams of physicians. One comes from a very famous medical university, medical college, and the other one comes from a much lower quality, if you will, medical college. So if you look at the qualifications of the people who teach or get into those programs, they're vastly different. But the two groups didn't get along with each other. So they used the last digit of their social security number. If it was even, they got the fancy doctors. If it was odd, they got the other one. So this sort of gets to your equity question of, is that equitable or not? It's sort of random. It's literally random whether they got this very prestigious set of doctors treating them or a set of doctors who didn't go to the best schools and so on. And what we found was that the less prestigious doctors ordered more exams, and they used more specialist consultations to figure out what to do than the more prestigious doctors. It seemed like the more prestigious doctors were either more confident or more knowledgeable, or they just got to what was wrong and they fixed it. And then we looked at mortality or other health outcomes, and they had the same outcomes. They had the same outcomes, which I found to be very interesting, because most of the time we see no difference in outcomes and difference in costs, and we say, aha, we found waste, that's waste. But in this context, it's possible, and we didn't prove it in this paper, it's ongoing research, do the less prestigious doctors, do they need the extra exams and consultations to get to the same outcomes, or is it truly waste? So when we look at these data, I've always wondered, is it really waste, or do they need to have some extra outcomes? And so maybe I'll close on that question, which is, when you see that some areas are doing much better than others, are there ways to get these people together and talk about why and what best practices are and sort of diffuse this information? Because you gave them one story, I thought that was very powerful. Does that happen more? How often do you guys help that happen?
Well, I think that the tools that you can use are surely public disclosure of data. That's the starting point, because then the first moment you deny, these are not my data, these are not my patient, you did it wrong, you didn't code well, right, and so on. But then after, I think that especially we have a lot of people working in the healthcare center that are always looking for sense. What I'm doing here every day, 12 hours a day, and most of them really work hard. And so they are the first one at a certain moment to ask what is going at the back, why this is happening. In our experience, most of the time, really most of the time, is something to do with the organization. The organization of care, and if you have the right things in the right place at the right time. So it's something that you can really improve in most of the time. What I think that in this way, I think Tuscany or even Veneto region, these type of regions have, as I told you, 3,700,000 inhabitants. It's like a large city. It's a dimension that we can still put in the same room all the head of the departments of the diabetic foot to discuss together what's going on. Or we can have a meeting with nurses to speak what is going on in a specific hospital. And this helps really a lot because in a way, we can't impose improvement. It's something that has to come from inside because the clinicians have the responsibility of prescribing. And that's their responsibility. So they really are in charge to find what to do and what to propose to patients. And of course, then you have the consensus of the patients. But, you know, this is really for the astigmatry we have. I think they have a really relevant role. So we have to put them comfortable to be in the conditions that they find the way of improvement. Yeah. This is really relevant. So in a way, the role of management is to support, not to decide. And it's a different way of managing in this healthcare system from other sectors.
Just also to make you more comfortable in asking questions, you can ask questions in Italian, by the way, so and next we translate. So se volete fare domande in italiano, poi noi le traduciamo, non è un problema, però era to make you more comfortable per stimolare un po' più di partecipazione.
I think that the last reference to research is crucial because one of the justifications for why the U.S. should be worth the expense by U.S. should be worth is the fact that the production, the new treatments, new innovations, they come from U.S. That's why the spending is higher, and somehow we also benefit from this spending because there are some externalities because this new treatment then they come to Europe and we are benefiting from these externalities. So how do you believe this is true? How much it is important actually for us to make reference to research, foreign research in this case, because it's US based, whereas we just have to catch up with what is done in the US. The constraint that we have, especially with aging population, is important.
Well, I think that you are especially thinking about the research you're doing on pharmaceutical and drug issues. So after I leave to Riccaboni the questions, when we look at these type of papers, they are divided in different specialties, but they are regarding a lot of different type of issues, not just a new treatment of drugs. It's also what you can do to avoid drugs and have more health, more outcomes, and why you are, so it's, I wouldn't say that this is the research that we're doing to catching up with the United States. If you go and see the results of Italian research in looking at the specialty and how I was placed, our research is very high, and it's incredible for me, considering how little we spend on research and how good our results, especially in cardiology or oncology, we have incredible good results in the ranking of our research. But I wouldn't say that are regarding just drugs. It's regarding all the clinical path and what to do in different stages. Well, I'm not a clinician, I'm a management professor, but what I can see, it's regarding all the clinical paths. So I would leave this question to Professor Riccaboni, because I think that you were specific interest on regarding the research that is carried out regarding drugs.
Question, or can we move to the last presentation? Maybe you can ask. Oh, there's one more. Bene.
La mia impressione è che stiamo analizzando dei fenomeni estremamente complessi nel senso che nell'andamento dei nostri risultati in sanità certamente conta quanto noi investiamo in sanità, certamente conta quanto noi, diciamo così, siamo bravi nell'organizzarci, certamente conta però quanto noi siamo capaci di formare medici bravi, quindi direi le variabili che contemporaneamente noi dobbiamo tenere presenti sono tante che credo ancora siamo a valutazioni che consentono per ora risultati in tutti i modi preliminari. Credo, ecco, che si debba approfondire il problema proprio perché la complessità mi pare sia veramente tanta e affrontare tutte le variabili credo ancora non ci siamo arrivati.
Ok. Oh, scusa me? Per me, mio italiano is male. So anyway, this question of teaching hospitals is fascinating to me. Do you want to be treated at a teaching hospital or not? And so one project I have looks at which ambulance company picks you up when you call 911. So when you call the ambulance, there are different ambulance companies that could arrive depending on who's available, who's closest to you at the moment. And if you compare neighbors to each other, you know, with tens of millions of observations, but essentially comparing neighbors to each other, one gets ambulance company A, one gets ambulance company B. Ambulance company A has an affiliation with a teaching hospital. Ambulance B is affiliated with a non-teaching hospital. So you get this randomization of which delivery mechanism you get to, and it turns out it affects where you go. And what we find is very strikingly that teaching hospitals get much better outcomes after severe emergencies compared to the non-teaching hospitals. And we know research is much higher in the teaching hospitals. So that's the type of natural experiment where we start to say, are these research institutions actually delivering better care? I think a question is, would they deliver better care if they were doing research or not? I think that's a good question. And this is now anecdotal, I don't have evidence on this, but if you attract people who want to be researchers, who, if they are better at research and also at clinical care, whether that's making diagnoses or skilled at procedures, if those skills are correlated with each other, then allowing people to do some research attracts the people that would do the best job in healthcare. That's the question. And I think we have some evidence that says that that's right. But I agree that more research should be done. But if you ask a researcher any question, the answer is, well, more research needs to be done.
Okay, very good. So maybe I can take mine.
Okay.
It works? Great. So I'm trying to take a different angle. As been said at the beginning, I'm mostly focusing my research on pharmaceuticals, pharmaceutical innovation, and also play a role at the Italian Agency of Drugs, AIFA. And so my main concern is, I'm trying to ask a different question here, is, okay, we have a good, high-quality healthcare system, as we've seen, and it's universal, it's kind of universal, and it's almost free, even if out-of-pocket expenditures were growing rapidly. And so we want to keep it as it is, so that's the consensus. And the question is it sustainable? Can we manage it? And I kind of collected some data here I want to share with you, and more importantly, and maybe I can move to the next slide, the question has to be put in perspective. So is it going to be sustainable in the coming years based on what we know are the main drivers of expenditure? And as I said, I'm mostly going to focus on pharmaceutical expenditures, but let me say that pharmaceutical is an important component of total healthcare expenditure, and as you know very well, it's increasing in terms of share out of total expenditure. So it's becoming more and more important in the coming years. Well, we have some of the key drivers are well known, and some have already been mentioned, like, aging population. That's a well-known driver, right? Income maybe is not as well known, but you see all the plots showing a strong correlation between GDP and healthcare, and it's a sort of luxury good, and if you have some extra budgets, it's worth spending money, especially if it's out of pocket, to get some more extra years of life in expectation. So it makes a lot of sense. So wealthy society tend to spend more in the public budget and private budget for healthcare. So it makes a lot of sense. And the third one, which is also very important, is technological change and innovation of all types. And you have to pay for quality, pay for innovation. It comes at a cost. And this is it's more interesting in a sense because it's less predictable. So we know not so much about what is going to happen, what are the new drugs that will be launched in the next few years, and how to make them sustainable, how to make them affordable. And as Professor Pietrini said, I in the last 3 years, I spent a lot of time negotiating prices. And so I'm kind of experienced, and I know that sometimes, especially if a product is new, and is the only one in the market, is for an orphan disease, is for a rare disease, there's little you can do to bring the price down. So it's almost take or leave. That's the price. If you want to pass it to the patient, that's the price you have to pay. And there's sort of little bargaining power we have, okay? Good. So let me start from very recent evidence, the one we are in the healthcare management with whatever role they know about this picture has been recently published. And I don't want to go to the details of that. This is the sort of trying to monitor if the pharmaceutical expenditure is under control. So if it is below the 6.89% threshold, and the red ones you see is the list of regions that are above the threshold. And as you can see, most of them are above the threshold. Tuscany ranks third in the list, so it's kind of well above the threshold. And only 3 regions are below the threshold. So as for what we call in Italy the direct pharmaceutical expenditure, meaning mostly hospital expenditures, we sort of spend 1.5 billion more than what was expected to be the expenditure in the budget, 1.5 billion. And it has been done regularly, it was like that, at least in the last 3 years. So I have another slide. So you can see a little bit of a trend. The column in the middle gives you the growth of the non-convenzionata, meaning the drugs in the direct expenditures by the healthcare system. You see, is growing at a rapid pace, and it was also 2-digit for 2015. So it's not under control. That's to put in just a single sentence. It's not under control. And how to make it sustainable? That's a crucial question, right? It's a crucial question at the national level. It's also more and more important at the regional level. Because as Professor Doyle said, in one sentence, you can easily go get bankrupt on this. Okay. I collected a few, some numbers, some figures, just to illustrate that the trend is sort of, like Armando Rungi said, it's not just the Italian trend. We are part of a global trend. And so there's little we can do as for the global tendency. And let me just highlight some of the key drivers. As I said, technological innovation matters a lot. And let me just maybe use this slide just to show you why it's so important. First, you see, that's for the FDA, but it's the same for EMA, the European Medical Agency, Medicine Agency, sorry. We have seen an increase in the launch of new drugs, new chemical entities, new molecular entities in the recent years. So there's a recovery in terms of productivity of R&D, which is good news to patients. So we get better drugs into the being approved into the markets. It's not such a it's not as good for the healthcare budget, of course, because they are very expensive type of treatments. And you also see the second one, it's also extremely important. The trend is well known, it goes toward personalized medicine. So it's sort, you're targeting narrow population of patients, and that strongly correlates to the price of drugs. It's easy to understand. So if you differentiate product, you customize product, you go more and more to niches into the market, there's less competition, and so price will go high. Just because of it. And as you also know the special legislation for orphan drugs, and so on and so forth. So all things combined, that's a key driver of healthcare expenditure. And there's some more, you see to 20 plus 12% in the oncology field, and we know that's class L in the classification system is the one which is growing rapidly. So a lot of innovation, that's why it's growing, but at the same time, it's increasing its share in total expenditure. Okay, I want to go very fast. So you see, this is also informative. You see, this is the compound annual growth rate projected. As I said, I tried to do some forecast about what's going to happen in the next few years. As you see, there's a change in the slope of the growth pace, meaning that now we're sort of ramping up. The expenditure is ramping up at the global level, and that's mostly because you see the orphan drug segment, that's kind of growing even more rapidly than the total expenditure. But overall, you see there's a growing trend. And so since we are being called to manage, to sort of use the same budget to cover all needs, it's kind of challenging, right? Because this is a sort of a global trend of raising expectation in terms of market size and what you can get out of the new drugs into the market for pharmaceutical companies. And the other side of the table would like to, make sure you spend the same year by year. And it seems like hopeless, right? Type of goal. All right, I said there's more drugs coming to the market. Here you can also see some of the names. Maybe you can recognize some, like 2014, Keytruda, Opdivo, Trulicity. They are all well-known drugs now into the market, meaning that they grow very rapidly into the market. Like in the last 3 years, now we are already best-selling products into the market, which is a signal they are very important, new treatments in the oncology field, diabetes, and so on. All right, maybe I can skip it, but you can see like oncology, how big it is, how rapidly it's growing, and what are the main products driving expenditure. Let me use the other slide, which is, I think, informative. So this is just for the oncology market. And you see how it breaks down total expenditures in 3 components, like existing established products, recently launched new products, and even more important, the gray one, new launches, okay? So you see what is really driving the raising cost in the oncology field. Okay, we are kind of keeping under control expenditure for existing products. There's some little growth, but not too much. The recently launched products like Opdivo, Keytruda, they are still growing very rapidly to the market because they extend indication and they get more, they sort of penetrate the market in terms of get more patients being treated. And this is very important. It's sort of getting chronicized, I don't know what to say in English. They get chronic patients. So because they can easily survive more than 3 years and being treated. So if you want to see the Kaplan-Meier curves, essentially they got flat after a while. So meaning that you get long-term survivors. And of course, they will pile up year by year. This is extremely important. So this year, maybe we didn't use all the budget, the fund for innovative oncological drugs, but keep in mind, next year is gonna build on top of that, more patients, build on top of that. So already next year will not be enough to cover, the cost of new oncological treatments. Okay, so the 2 elements here are very important. So innovation comes at a cost, and horizon scanning is essential because you see that in the forthcoming years, we are going to spend even more. We get more drugs into the market. We get the line extension of the existing drugs. And, this is kind of scaring to me. I don't know exactly how to get it affordable for our budget. All right? Some words of hope. Well, there's also some drugs into the market. This is simply the list of the best-selling drugs in the world. The first thing you read in the list is Humira, and Humira is gonna turn off patent, goes off patent in the next. So it will be nice to get some room for biosimilar drugs in the market, because we already have biosimilars for many of the indication of Humira. Is the top-selling drug into the market in Europe, going off patent, not in the US, which is maybe part of the reason why there's a gap in the expenditures in the US. They're going to be protected for, I think, 5 years more, something like that. But in Europe and in Italy, it goes off patent. And so it's extremely important to get some, like to encourage use of biosimilars. That's a way to save money. And since it's the first best-selling product in the market, that's extremely important, right? I also want to point your attention to the third Revlimid. Of course, the practitioners and the physicians may know what I'm talking about, but maybe it's worth considering that the third blockbuster drug in the world is an orphan drug. So how can it be? Orphan means it's for rare diseases, right? So it should be for just a few patients, okay? Just keep in mind the third best-selling drug in the world is for orphan indication. Maybe there's something wrong about the orphan status, right? Maybe at the beginning it was an orphan drug, but doesn't make sense to keep, calling a Revlimid an orphan drug now? Okay. So that was the special legislation was meant to encourage investments for unmet medical needs and rare diseases. But, now it's also, Revlimid is part of that game. Okay? I just want to skip that, this is just to reinforce the message that orphan drugs is one of the most important segments. You see that the share of orphan drugs out of the total is increasing. And maybe this plot is trying to convey the same message. So you see what is the mean cost per patient per year of orphan versus non-orphan drugs. Now, back to the point. Just that you see there's a gap. The gap is widening. And let me take a closer look, but it's sort of, you pay 5 times more an orphan drug than a non-orphan drug. This is the message here, right? Okay, rare disease are important, orphan patients are important, but it comes at the cost. So you pay them 5 times more. And remember, the trend toward personalized medicine it means that you get more and more orphan patients. And every time you transform a wide market into a set of orphan sub-markets, you do times 5 in terms of average cost of treatment. This is important to keep in mind. We all like personalized medicine. We all like customized services, but it costs 5 times more. Okay? They are also more effective, of course. I'm just saying, cost effectiveness maybe makes sense, but in terms of sustainability, it's a huge challenge. Okay, at the same plot here, you see this is just showing for a bunch of orphan drugs, the number of patients on the x-axis. On the y-axis, you see what is the revenue or cost per patient. This is from the perspective of sellers of pharmaceutical companies, revenues per patient. Okay. I'm kind of done. Europe, the same. You get many. This is the number of orphan drug status drug approved into the market in Europe and by other agencies in the world. And this is just trying to. I stress the fact that it's very important trying to forecast what's going to come in the next few years. And I just want to use 2 well-known examples: gene therapy, cell therapy. And let me see if the pointer doesn't work, but you see there's 2 columns. One is 2017, and you see the sales figures for 2017, and most of those drugs is just not in the market yet. So sales figures are 0. And next you see nearby the column 2024, that's the projected sales, expected sales by pharmaceutical company in 7 years from now. And you see it's really, big in the next few years into the market. So cell therapy, gene therapy, we haven't seen them yet, but they will come to the market very soon. And by the way, we already negotiated a couple of treatments also for the Italian market, and the average cost is even higher than the cost we are paying, like CAR therapy, even higher than the cost we are paying for the most expensive orphan drugs we have in the market so far. Okay, this is sort of a scary picture. What we're doing here at IMT with also some students like Jan, who's sitting there, who's a PhD student at IMT. What we're trying to do is trying to give our contribution to better forecast what's going to happen in the next few years, building predictive models. And to build predictive models, there's some elements. One is to use the data and use machine learning to get information out of the data, trying to predict, this is the first step, if a drug will ever hit the market, or if the drug is going to be launched and when. And the second element is what is how much expensive is likely to be that drug, and what is the population of patients, the epidemiological data about the size of the patient population. All right, so, and this is very challenging, but it's also extremely important, because it will contribute to better understanding of what are the future trends of healthcare expenditures. Let me just add a couple of more words, and colleagues already mentioned the silos problem. And 1 year ago, this was the budgetary law of the Italian government, has been stated that for innovative drugs, we should experimentally launch a monitoring of how they are used in the Italian system, and that's the most important innovative drugs for which we have special funds are hepatitis C treatments and oncological, especially melanoma treatments down there. So we sort of right now trying to monitor how those drugs are being used, because on one hand we said they're very expensive. On the other hand, they save life, which per se is also very important. And so we should also make some political decision on how important we consider it is to save life, to get people being productive and a good quality of life and take part of our society. But at the same time, when we negotiate prices, they say, okay, but maybe you can save money, healthcare costs, like you can avoid surgery. And, well, is it true? Is it there? Is there any saving you get? And so maybe you can argue that if you spend more for drugs, you have to spend less for hospital care. And I don't think the audience will agree on that. Or you can just reallocate expenditures to make them more effective. But the general question is, are they really cost effective in the real world? Because we see on paper, they do all HTA and cost effectiveness studies, and you see a lot of assumptions there. And nobody go and check, or let me just if it really translates into some savings in the real world, or if they are really affecting the real world. The good thing is in Italy we got registries set in place. This is good. Maybe it's better now. I take the fifth and I'm going to say anything about the quality of the registries we have in Italy. But let's say we can improve in that respect. It would be nice to get some real-world data we can use, okay? This is my really last slide, so I'm just trying to, no, this is not really last one. I'm just showing some recent studies. We're using some real-world evidence, and as I said, it's important we get data, and we'll try to do some, also that's very important to have a control group of untreated patients so that you can really make sense of what you gain in terms of healthcare outcomes in front of vis-a-vis the extra expenditures to the healthcare system. And this is the last slide, I promise. And let me just say a few words. So far, we try our best to make it manageable and sustainable. And one of the attempts was to use complex contracts. And somebody mentioned complexity, and we sort of became more and more experts in the complexity of the system. And what we have used is some complicated mechanism like payment by result, management entry agreements in general, with lack of transparency. That was another keyword which has been used. How transparent the system has to be? Well, the hepatitis C case is a good case because it wasn't transparent at all. we negotiated a price, and the price was confidential. Confidential up to the point that it was supposed that nobody, even local healthcare authorities, should not know about the price. Okay? And let me tell you what, there's a trade-off here. If the price is not confidential, you see them up there, there's an external reference pricing mechanism set in place, meaning that when a company comes to negotiate a price in Italy, they say, okay, if you want the price to be transparent, since France, Spain, Greece, they all use Italy as a reference country, we know that they will sort of set the price at the same level. So we're going to lose like some market in Europe. So you want it to be transparent? Good. It's going to be a higher price. If you negotiate a confidential price, you get a rebate. And next, I let you choose what you prefer. Do you prefer transparency or do you prefer a rebate? Okay? But this is just, to be practical about that, this is a real world trade-off. If you want it to be transparent, it comes at a cost. So transparency in this business, it's expensive, okay? So, but there's a lot of things we can improve in terms of transparency, but that we are part of Europe, and that's the external reference pricing system we are part of. And it was a real nightmare, because, you see this curve, so Valdi Arvoni, we got a price volume mechanism set in place, meaning that if you pass some threshold in terms of, number of patients being treated, the price goes down. So the initial price wasn't transparent. And the prescribers, they did not know how far they are from that threshold. Also, you get multiple drugs in the same market. So you see two curves here. And if you ask even a PhD student at IMT to solve this problem, saying which one is the most convenient drug to be used, and try to solve it by not knowing which one is the less expensive one today, and how far we are from the target of reaching, the next step to bring the price down. Okay, this is just crazy, huh? It's impossible, but that's the way it has been designed. So complex system, it's extremely complex system. Nobody can understand. You sort of prescribe a drug, you don't know how much you're gonna pay that drug. And this is maybe a bit too much of complexity as something that we can't afford in terms of really understanding how we allocate our budget, how it has been used to treat people. I think I'm sort of done. I also very important, to financial concern. This is also something that maybe just to stimulate some discussion. Typically, people do not take into consideration the financial aspect, just the cost. But the point is that you can get, say, a discount. It means that the price goes down, and that's the price you pay from the very beginning. Or you get, say, a payback, okay, at the end of the year. Payback at the end of the year is not just having your money today. So if you have a bank loan, you know it very well. But for public administration, it seems that it's not so important, maybe. But of course, since we are like under huge, severe budget constraint at the national level, we should try our best to get the money being paid as soon as possible. And there's another aspect, right? Because when for hepatitis treatments, in the beginning there was a payback system, and next we sort of get it transformed into a rebate. That goes back in terms of, we call it not a decredito, but sort of part of the invoicing system. And regions complain about that. I ask, why? Should be an advantage because you get your money before. And I've been told there's a huge difference because if it's payback, it goes to the regional head who has power on the budget. If it is a rebate, it goes straight to the hospital. And you lose your discretionary power on what to do with the budget, right? And this is weird. So let me stress the importance of the financial aspect. You desperately need that money. The sooner, the better. Thank you very much. right, maybe I can just ask again if there's any question. It seems we're all tired and we had enough. Oh, that's one.
I've read that every year in Italy you waste 2 billion euros on medicine because people buy it, but they don't need it. Because the legislation says that you cannot get only one pill if you had a headache, but you have to get the entire box. So then the drug arrives to the deadline, so you don't. People just throw away 1 kilo of medicines in Italy. So. These 2 billion euros, if we change the legislation, would improve the gap between the estimated budget and the real budget. So this money could go into innovation or to other useful resources. Do you think this is the case?
Yeah, since it's about drug, let me try to answer. So first, some drugs, like we call it in class C, it's sort of patients and families that will pay on their own. This is also important because we should avoid the waste of drugs, but it doesn't go in the public budget. But let me just give you an example. Orphan drugs like Fabry disease, which is a rare condition. Okay, treatment and packages are based on the weight of people. And the point is that when you really see the curve, it's supposed to linearly increase with the weight. When you're a baby, it goes up like this. But because of the packaging, you see some huge jumps like that. And it is extremely expensive drug, and rarely a hospital is going to treat more than one patient at a time. So essentially, you're going to throw away those drugs to a very large extent. So there's a lot of waste also for highly expensive drugs. And to find a way to save on that will be extremely, to make it more efficient. Maybe Sabina also knows it very well, like, how to find solution. Now there's also some technologies in the hospital just to prepare dosages for patients and make sure to trace them to the patient, make sure there's little waste, order on time for financial aspects we just mentioned. And so it's extremely, I agree, it's extremely important.
And another question, I was thinking that marketing influences people's decisions. So maybe the the orphan drugs that are sold more than the non-orphan drugs maybe are because marketing influences people to buy drugs that they don't need just in order to prevent something that they actually don't have a risk to it. And also marketing influences doctors to give new drugs to patients and they give them money in order to, if they successfully tell their patients to get something instead of another drug.
It's about drugs again. You want to say something?
Well, I think that of course, we have this type of problem, like all over the world, regarding the pressure that we have from commercial advices and so on. I think if you go and look at the television, you will see an incredible number now of products for stomach problems and so on. And it's really something, it's a big pressure. Now that soon young students drink, they have a problem with the stomach thing, they go and get this product. And I spoke with a lot of clinicians that were telling me that this is really a big problem because this idea that the young people can care without going through a GP or about a specialist. They just go and buy these drugs, and this is something really very negative. So I think we have this type of issue, especially in Italy. I think it's a large problem because the Italian person like to get medicine a lot. And this, you can see it in a lot of products like drugs like antibiotics. We have a big problem with that. Antibiotics, we are consuming really number of antibiotics is very high, and this is a danger also for the future health. So I think this is something to do with the more education of all the stakeholders of the system, the patient, the population, and also GP and specialists. In a way, sometimes, you know, the person to go to the GP has to come up with something. And so at the end, we prescribe things just to, and this is something that we should absolutely improve. Or for example, if you go and see the number of old patients that has more than 10 different principles, and so of course at the end you can have negative effects if you get too many different type of drugs. So we have these indicators. We try to work a lot, especially with GPs on this, so that they are more careful on what they're prescribing, and what are the, and if we also have the effect that's very large in Italy of patients that have some medicine, that are prescribed with some medicine, then they go home and they will get what they want. We have this very large problem. We went through, for example, the problem of beta blockers. Everybody agrees on the idea that for specific needs you need these beta blockers, and then we have a very low number in the real world, the data of patients that are effectively getting this type of medicine. What's going on there? They have the prescription and they're not using the medicine they should get. And there is a lot of also cultural elements, especially low education patients. They feel better and they divide the medicine in two and they get half of the dose. So I think we need to do much big work in trying to provide the right drugs and prescribing the right drugs, but then also to measure if they are really, if the patient who needs these type of drugs are using them, because we also have this type of problem. Over prescription, but also good prescription, and the patients are not following the right prescription. So it's a really very complicated element we should work on. I agree.
I'll just say briefly that the question I'm interested in is what's the right rate of use of drugs? So marketing increases the use of drugs. If you think that's bad, that means that you think we're overusing them. If some drugs we're underusing, then of course we want drug companies to be educating doctors and patients, but we know that we take it with a grain of salt, you know, that they're marketing. So then we have regulations about, do they have to give the whole story? So in the US, we have advertisements on TV. You're watching a football match on TV, and then there's an ad for a drug, and that they have to list all the side effects. So it's like a very depressing way to enjoy a football game, to hear 20 side effects from a depression drug. But people will learn about the drugs that way. So the question is, do we want them to learn about it? There's a benefit and a cost to the advertising. Yeah.
So let me meanwhile say something. So if you mean by waste all type of misuse, overuse, of course there's a lot of waste. Another important aspect is adherence to therapy, right? You have to take a drug regularly and maybe you forgot and the drug is no more effective, but you're still spending the money. So, and this has to be with the habits, as we've been called, behavioral aspects. And so by working on behavioral aspects, maybe nudging people or just have to remind to the elderly population, you have to take drugs every day. That way you make the system more effective and you don't waste money. So there's room for improvement in many respects. Just a minute.
So related to wasting money on medicine, the question is about the importance of the prevention. So I'm guessing when you compare the life in Italy and in US, there is a huge difference both with respect to what people eat, but also how people live their lives, how much they work, how much they enjoy their life. But there is also, of course, downside, because in US, I guess people work more, but this affects the GDP and increases the productivity of the whole economy. So there is also the trade-off, but there is also the kind of this prevention story. So I don't know if you have some estimates how this particular aspect is important in determining the overall cost of the health system, and how is it important in all of this big story about the health system.
So it brings up the point about how much of health, what we want at the end of the day is health. And we measure healthcare spending, and healthcare spending is just a very small part of what makes you healthy. Lifestyle being a major one, I think stress. We just don't know. We don't know why Japan or Italy, people live longer than in other countries. We could speculate, but there's a social safety net, there's a family safety net, there's stress, lots of other things going into it that I'm a firm believer that we have to go outside of health care to think about health. This is where the social determinants of health type of studies come in. How do you change people's habits to eat healthier, or even loneliness? So if you think about social connection, there are randomized trials of trying to partner lonely elderly folks with health coaches, or partnering with a university to have university students, pre-med students going visiting them, and they are helping them understand their disease, but mostly it's a companionship issue. So to me, it's we don't know the answer to your question, but I think this is a very hot area of pushing on improving health, not so much through healthcare, but through many different aspects of a person's life.
Well, I would like to make a question to Professor Riccaboni. Well, in the presentation you showed us, you talk about some tools, really important, managed yearly agreements, and others, conditional reimbursement system, risk sharing, cost sharing, and payment per result. I would ask you how they have a new role in this new era we are approaching. Now, in an era where we have protective medicine, customized medicine, personalized medicine. So how can you think they will change in this new era?
Oh, that's a very good question. So let me just say that the way it's been implemented so far hasn't been, say, cost effective. So we do a lot of cost effective analysis of single drugs, and rarely we do cost-effective analysis, let's call it this way, of policy intervention. So if you pass a policy like you want to have registry, you want to monitor, you want to manage post-launch and just pay for outcomes, well, you should also measure what is the administrative burden to fill data into the registries, how many registries you have, how much you pay for each and every registry, what you do out of it, how frequently you get some savings by doing that, so on and so forth. So that has not been done. And my feeling is that if you really do a rigorous assessment of how effective they've been so far, but easily you get disappointed out of that, right? Because it's very expensive, it takes a lot of time to fill in data, and nobody using those data in an effective way. Even us, because when we go to take a look back into the registries, and so, there's maybe it's a single detail, but in the contract you sign, you say, okay, what is the expected savings of this clause of payback based on results? Or we expect 15% less. Okay, so we write in the contract, say, okay, if it is 15% good, if it's less than that, we still want a 50%. So, if that's the deal, why don't you give us just a 15% rebate? And my general impression is that one of the main reasons why I prefer not to do like that is, again, lack of transparency. Because in a complex contract, nobody can really understand how much it will cost. Or you have at least to wait until a few years when you get the data, and only then you do all the accounting, you know how much you pay every single treatment, right? And so there's no way for other authorities around the world, for payers, for everybody, to make real sense of what is the cost. This is on the negative side. On the positive side, sometimes you really need to find out solutions. Like as we take the CAR therapy is one-off. So it's a therapy, it's extremely expensive. You treat a patient, maybe he gets, you hope, he will, since you pay a lot, you hope it will really solve the problem, cure, and so you want to, maybe a payment member is just saying, okay, if he gets cured, I pay, otherwise I will not, right? And this is important. Second aspect is a lifelong type of benefit. So maybe, yeah, I treat you now, I spend, say, easily, like this is one of the prices that we have right in the market, like 300,000 euros upfront in a for a single treatment, but you're gonna live, say, 40 years more in good health. Is it worthwhile to live 40 years more and spend as much? And is there any financial solution so that maybe I can pay you over 10 years instead of just paying you now? Or find solutions like that. So those type of contracts on the positive side can also help you to make expenditures more manageable, more affordable, and look at long-term benefits, relate conditional sort of pay for outcome in a long-term perspective. I think that's a positive aspect. And since we're getting experience in filling data into the registries, maybe there's a learning curve, and we can now take advantage of what has been set in place and just try to make it more effective.
Good morning. Thanks for your presentation. I work on patient safety, and so I was wondering whether you think we are ready also to publish data about inappropriate and unsafe treatment, given that we all know that there's a publication bias related to the RCT and the pressure to just or eventually facilitate the publication of research with good outcomes for patients. While on the other side, it is hard for us at the hospital level to measure let's say, what's behind the variation, if we had inappropriate prescription and treatment or even unsafe care. Up until now, I cannot tell you the number of medication errors that occur in our departments. That's a reality. We just have some post-hoc data about adverse reaction and effects, but just a very limited number to what is expected according to evidence, because we know that 1 in 10 medications given in a hospital in one day is wrong. So I was wondering whether you think we are ready to produce and publish this data about appropriate prescription and treatment, both in terms of research and practice for the evaluation of our services.
So the idea of adverse events, there are adverse events and there are adverse events caused by the wrong drug. So this is a complicated issue of how do you measure that. And so in the end of the day, if we have cancer drugs or something, we're looking at survival. And if things go wrong because of the way they get administered, that gets to the system's point of view. So how are the systems in place in order to get to the right drug? So my impression, speaking with large healthcare providers in the US, is that we're pretty far from knowing whether there was a mistake in the right drug, and then the adverse events after they leave your hospitals is we're far from being able to accurately measure that. So that's a goal of everyone, but it's expensive. So we need to have more than just rhetoric about it. We need to have funding about it. So maybe Massimo can talk about, we require drug companies to have lots of funding, billions of dollars on stage 3 clinical trials, but what about the stage 4? Are they required to track the adverse events and report them in the right way? I think, shifting the cost burden to them obviously has benefits and costs as well, but I'd like to hear, where's the state of the art there?
Well, I tend to believe that this is very important, the publication bias you mentioned, right? So people, like we are researchers, and we have incentives to write a paper, to get it into a journal, and maybe there's a lack of independent research and back to transparency, access to data. This is very important. Recently, many authorities disclose information about clinical trials, even failed clinical trials, so to improve what we can learn out of the evidence. And I think that will be should be much easier in future to reproduce results and to try to validate results. At the same time, there's a lot of misconception, rumors, fake news, and about what works and what doesn't work. So this is a side effect of not being able to reproduce and validate and replicate. So it is in the press now that we have fake news about vaccines and things like that, and this I think is somehow related to the publication bias, right? So which source can you trust? How can you get data being validated? And also how to properly interpret, say, pharmacovigilance reports. Because we get a monitoring system, a surveillance system set in place. It's pretty good. But who should take a look into that? How can really interpret what you get as the feedback information? And it should be an expert, right? But there's a tendency, we already discussed, to a higher empowerment of patients, of GPs, and so that goes more and more in the hands of the final customer, let's say, to use the economic language. And from the information point of view, there's some compelling reason why you need a prescriber, right? Just to put it very simple, it's because typically you don't know what you're doing. And so I think that we should sort of find a good compromise in terms of access to information and the way people can really use the information to make a good decision.
Can I just say very briefly? So my goal is to have healthcare providers, large providers or payers, have this new ethos of trying to figure out if they have a large change, did it work or not with a randomized trial. Now, when they partner with an academic, we have to pre-register the trial. So if I look at the types of programs like prescribing fresh food, I can look to see in the registry all the other researchers who have pre-registered, and if they don't have results, you can sort of start to infer that they didn't have good ones. I have a study that will be coming out, finding zero effects. We're going to publish it, because we've pre-registered it, and we made it very public that we're going to be studying that. So that's the type of transparency that comes from partnering with academics. If you're a pharmaceutical company and run 1,000 experiments and only report the 2 that worked, there's less credibility to that. Even in a Cochrane review or like a summary of the evidence, the gold standard used to be a clinical trial. Now it's a clinical trial by somebody who doesn't have a conflict of interest. So that's not to say we shouldn't have research and listen to what the studies say from people who do have a conflict of interest, but the highest level of credibility will come from partnering with folks who have no conflict of interest. So I think these are all things that I think we're making advances because of the concerns that you have, and let's keep doing so.
Just add a question, especially to Professor Riccaboni. I was wondering, thinking about the issue of independent research. And what you think about the story that sometimes comes out on the papers and regarding the issue that a lot of these innovations in pharmaceutical drugs start from public university where research is done and then it goes in spin-off, and then the spin-off is sold to a big company, and at the end the big company does a lot of profit, and governors that have financed the public research have to pay the profit of the pharmaceutical companies. So what is the message that we could give to our policymaker, and how can this be, in a way, at least be a little bit more under control? Because this, I think, the last stories are really impressing from this point of view.
So it's a huge problem. In the US, I think they've made a lot of progress because a part of disclosing in the publication that you're being sponsored by, say, FDA, NIH, whatever, even for patenting rules, there's some limitation if the patent comes from some research which has been done, has been sponsored by the federal government. But the problem is widespread, and I think it's radical and is still in search for a good solution. Let me make a case since we mentioned orphan drug. So the typical path for an orphan drug development, and I did a study which was really narrow on Rett disease, which is a rare syndrome. And if you really look into the details of research in the early phases is, as you said, university labs, the academia in general, hospitals, they make some huge investments, and families. So they volunteer, and sometimes entrepreneurs, they have some parents who have got the disease, so they're really concerned parties who really make the huge effort at the very beginning. And that's all on voluntary base, and so it's not for profit. It goes so as far as going into the trials and get it patented. When it gets it patenting, the games change. And you get this company, and the price is, as I said before, that's the price, take or leave. And you forget about not just, you touch upon who sponsored the research. It was public money. Not just that, is it also who really pioneered the field and who really put the entrepreneurial effort into doing that. Okay, it's totally disregarded, you know? And this can be like that, you know, on both sides. It's a matter of you don't want to pay things twice. It's a matter of if it was a social effort, it should go back to those families, you know, to make them sort of relevant stakeholder at the end when the drug gets approved. So I totally agree with you. I think it's a huge problem, and it's especially severe for orphan drugs, where really you see many, not just the public sector, but even non-profit organizations will play a huge role. But this is sometimes the case also for infectious diseases, also for.
Again, thank you for the presentation. I have a question for Professor Riccaboni. You mentioned that in the future we will have a very niche product, and in some cases also with immature data because of accelerated regulatory procedure. So my question for you is that, do you consider that real-world evidence can play any role in supporting to understand better the place in therapy when it comes at the local level or national level? And if yes, which kind of real-world evaluation can be done? Because I suppose for orphan drug will be very difficult in some cases. And I have a second question, sorry. Do you think that the oncology register in the future can play and support the data for the clinical practice, can show any clinical practice?
Well, it's a complex, back to his point, it's a complex issue. Just to come up with a short answer, let's say that the information system is really fragmented. So registries are managed at the national level, and next you get some data comes from hospital, which is better quality, and they should be somehow integrated. It's part of the silos system. Maybe we didn't say anything about that, but part of this silos problem has to do with the fragmentation of information systems and duplication of the information systems, which make it very difficult to work in terms of big data collection, integration. So that takes a lot of time, I think, to be implemented. And recently there's been a publication which has been largely debated about oncological drugs, just reviewing the drugs which has been approved in Europe in the recent years, and most of them are based on early evidence of effectiveness and accelerated approval. You go back and check if they really deliver based on their promises, and you see that sometimes they really don't. Right? You get some the classical cases, overall survival that comes after a while, and when you get the overall survival data, they fall short, and so you maybe pay more than how much is deserved for those treatments. And this is a problem for accelerated approval, but it's also a problem of price revision over time, because if there's a new and more effective drug, on the one hand you want to say, yes, I want to pay it more, but what is the benchmark? And so maybe you also want to revise down the price of a drug which is not as good a bit older, and so to make room for innovation. Otherwise, under those budget constraints, there's little room for innovation, and we should accept it. I think there's sort of misconception of what we do in our country in terms of sustainability. Let me stress this fact. Everybody, we like it to be universal. We'd like to get all the drugs, the best possible drugs which are available, especially when we are sick. At the same time, we are short of money, and you have to make the system more efficient. And I think that the work Sabina is doing is extremely important. So if you don't get efficiency gain, there will be no room for innovation, and we must accept it. There's no more question. I think that we are all tired. And so thank you very much for your attention, and thank you very much to our guests today.